Respected chairpersons, friends, delegates, active postgraduates, good day everyone. I would like to thank the organizers of the National ISA Con Ahmedabad for giving me this opportunity to talk about something about low backache and management. It's a vast topic. It's a vast topic. Whenever I talk anything on academics, I put a big salute to the legendary teacher of 2 centuries, Professor Ravi Shankar, is currently the director of e-learning in Mahatma Gandhi Medical College, Pondicherry. So when we go about what is Stoneman syndrome, everybody is liking to read about it. What is Austin Flint murmur? My professor used to tell only Austin and Flint have heard this murmur. But we are not bothered about any disease which affects 4 out of 5 people at some point of their lives. 80% you can see some point of their lives. A chronic low backaches prevalence is around 4.2 in 39 years and 19.6 between 20 to 60. See, this is a big burden and absenteeism, office absenteeism causing economic burden. Yes, I already told you the topic is very vast. Let me stick on to what is in chronic and what is in adults. It's a pain syndrome in the lower back. What is the lower back? Between costal margin and inferior gluteal folds. Between costal margin and inferior gluteal folds, at least for 12 weeks. Now we are sticking on to chronic and adults. Now, can we divide like this? Causes, risk factors, flags, diagnostic test, prevention, and management. What are the causes? We can say mechanical, due to injuries of the spine, discs, soft tissues, disc herniation. And don't think always this disc herniation is the cause. Pregnancy is a cause of mechanical back pain. Postpartum back pain. Postures, bad postures. Degenerative, yes, osteoarthritis of the spine, sacroiliac arthritis, spinal stenosis, etc. Inflammatory, ankylosing spondylitis and sacroiliitis again. There may be oncological, pathological fractures. You can see if there's 75-year-old male, if he develops a backache, just going on for some weeks, but it develops suddenly one day. Yes, I got up from a rickshaw. Suddenly the pain started. Then it is likely to be multiple myeloma in a 75-year-old male. Yes, likely. It's not that common. Like infections of the spine, epidural abscess, soft tissues. Yes, these are all the causes. For example, mechanical, traumatic, inflammatory, oncological, all these things. Where is from the pain starts? This is called pain generators. The pain generator may be spinal cord, maybe vertebra, maybe disc, maybe spinal nerve, maybe facet joint, maybe the ligaments, maybe the disc, etc. Or there may be a lot of muscles. Or it may be from the abdomen. It may be a prostate problem, gallstones, kidney stones, aneurysms, etc. These are all the possible pain generators of low backache. Idiopathic, that is what is very common people say. My teacher used to say, idiotic on the part of physician, we don't know what is it, and pathetic on the part of the patient because they don't know the cause of the disease and they don't know the treatment also. Now we have completed what are the causes like. Now we will go to the second risk factors. Age, maybe middle-aged people, females are more prone, weight, obesity is directly linked, and some stress. Here you can see the females more common. We can see the obesity, and here you can see how much the vertebra has to be taken care of. This big fat. Here you can see now this is almost easily balanced. You can see the age. This is the high age. Weak abdominal muscles and seeing the computer and bending. This is very common in this area. Computer or whatever it is, the workload, office clerk, whatever it is. Weak abdominal muscles. And this is what I say is a postural cause of chronic backache. Now, we are told what are the causes and what are the risk factors. Yes, if you want to go back, we can see this red flags. Pain, very young age. It's not relieved by rest. We have given some as a clofenac brufen for some time. It is not history of malignancy. There is a HIV patient. There is a fever, loss of appetite, weight loss. All these things point out to we are missing something. Go and investigate seriously. High fracture risk. Neurological, if the patient has got bladder dysfunction, severe morning stiffness as a primary complaint, inability to ambulate, he cannot walk or she cannot walk. All these things are red flags. Again, I am telling you, young patients, not relieved by rest, not relieved by 4 weeks of treatment, history of malignancy, some immunosuppressed status. I will always ask for systemic signs. Is there any loss of appetite, loss of weight, fever? Is there any osteoporosis risk, fracture risk, any neurological impairment like bowel bladder dysfunction? Yes, he cannot walk, he is lying down after backache. All these things are red flags. There are yellow flags which always point out to patients' personal moods, depression, dissatisfaction, problems of work at all, family overprotection, or little support. Now, is there history? Is there an underlying disease? It is very important because a patient may have rheumatoid arthritis, patient may have a severe diabetes. All these things, is there an underlying disease? Was there an injury? It's very important because the patient will forget that injury. An injury need not be on big hit or road traffic accident. It may be a small, stressful, sudden bending also. A small, stressful lifting of a 15 kg gas cylinder or something like that. What is the duration? 12 weeks, 3 weeks. How is the onset? Is it insidious or sudden? That's what I told you. Sudden onset, 75-year-old, think of multiple myeloma. Neuropathic or nociceptive. This is very important because neuropathic means it is burning, pinprick sensation, all these things. There will be an intervening normal area. If there is a nociception, for example, a fracture, for example, an abscess, the pain is constant, dull aching. There is no pinprick sensation at all. It is increased on coughing, sneezing. Beware. Morning or night. Is there an abdominal pelvic problem? For example, the patient has got dysuria, urinary infection, fever, backache. Yes, think in terms of those things. Yes, in exam, now we have got covered the history. Don't jump into the back if the patient has got backache. See the pulse, see the respiration. Basic things. If the patient is anemic, very basic things, because they may give some clues. If the patient is mildly icteric, all these things may give a clue. You go into and see the other joints, other systems. Maybe a rheumatoid arthritis may be associated with a rheumatoid lung. All these things, other joints. If the patient is on any drugs which cause arthritis or a low back, a mood or social status, don't jump into the back immediately. So what are the basic tests if you want to say, I'm going to examine, I'm going to complete the backache examination, straight leg raising. Patient is lying on the back like this. We have to just passively lift the leg like this. Yes, around 30 to 60 degrees. If the patient is having pain in the back, then it is possibly a disc. And if it is more than that, then it is likely to be a joint related one. We can have cross DSLR also. Yes, the pain is basically here in this side, but even if you lift it up here, the patient has some pain. What is Bragard's test is just, if you don't have pain, just dorsiflex. Even in 30 degrees, if you dorsiflex, the disc is going to be painful. SLR and lumbar, this is what is straight leg raising or Razik's test. Lumbar disc herniation can be easily diagnosed with manual muscle testing, supine red raising, Lasik sign, crossed Lasik sign. All we have discussed. Recording angle is very important. That is what I told you. Maybe up to 70 degrees, yes, in ligament laxity. Around 70 to 80, patient is having pain, maybe disc. And more than 90, it may be joint. Dorsiflex, that is Bragard's. Again, if you flex the knee, the buttock pain will get relieved. This is very important. Again, you press on the sciatic. Again, it will come. This is bowstring. One leg hyperextension test or stork test. Now we have covered the basic examination. Don't go jump into the back. First, all the vitals, abdomen, all these things. Then jump, go to the back, see whether there is any spasm, any tenderness, abscess, or anything like that. And then go to the basic test, straight leg raising. This is one leg hyperextension test. Here is in one leg and is hyperextending the back. This is a pars intercolaris defect. What is Adams test? Here is just this. Here you have to palm has to sit. There is no hump and there is no scoliosis. What is facet pain? We all are actually thrilled by this facet and facet injections. Interventional pain relief. Yes, we need, everybody is an interventional. We also do interventional anesthesiologists. Everybody intervenes. So Jackson was able to correlate some features. Old age, previous episodes of low backache, normal gait, but lumbar extension will be painful. No pain with Valsalva maneuver. No leg pain first. That is very important. A facet pain will not produce something like leg pain on the back. There is muscle spasm is not there. So these are all point to a facet. Sacroiliitis, I feel my practice, it is very common here. That is what I do. Faber said. Yes, press on. First is 14 finger sign. Press on the sacroiliac joint here in the back. Press on the joint. It will be painful. And Faber's test is reproduction. I will show the video now. Yes, go in, flex and yes, you see abduction and externally rotation. It is very painful. If it is reverse, extension and internal rotation, that is likely to be piriformis syndrome. Pain in the back or buttock. Yes, this is piriformis syndrome. Usually what I do is I give steroids in the muscle, and what else we have to study. Carda equina syndrome, I have already told danger signs or red flags. If you have a motor sensory loss, new urinary retention, you need to cooperate or coordinate with a neurosurgeon or orthopedicians. Saddle anesthesia, sphincterectomy. Second, you cannot go on treating something with progressive motor deficient low backache with epidural steroids and all, unless the neurosurgeon gives it an okay. Injuries, fracture, significant trauma, prolonged steroid use, osteoporosis, all these things may be severe injuries. Yes, we can palpate for contusions, tenderness. We are all worried about anesthesia and backache. Many patients are worried. Yes, if you give spinal, if you give a prick in the back, I will get a backache. I will not do my work. I cannot do operation. There are innumerable studies to say maybe mild up to 11% only for 1 month if we have spinal anesthesia. But always tell them the incidence of backache after general anesthesia is also up to 20 to 40%. This we should tell the patient, but because they think that prick in the back will cause backache. Now, what is common? I will put it as mechanical, postural. Yes, that is very common. Disc is common, and for a very bad, you have to invest in your chair. You have to invest in not in mutual funds or anything like that. You have to invest in your chair. That is very important. Sacroiliac arthritis, as I have told you, flex the hip and just externally rotate. You can find it out. Faber's test. Disc, yes, we know. SLR, straight leg raising. Myofascial pain syndromes. It is very common. And I will come back to this. Injuries. What are the other causes? Yes, polyarthritis, vasculitis, it may be pancreatitis, it may be a pelvic disease, migraine and stress coming onto the back, a premenstrual syndrome. Myofascial syndrome, this is very common. Any patient will backache. Just press on the medial side of the back of knee. Just press on the medial side of the back of the knee. If you have a trigger point here, you give some local with just 1 cc of steroids. Yes, the backache is likely to decrease, whatever be the cause, because the backache may be associated with a secondary myofascial pain syndrome that will go off. Your pain was score is likely to decrease. Yes, migraine, backache will also decrease. Very important. I have encountered this condition very commonly here. In pregnancy, for example, 8 months, 9 months, you get severe backache. The surgeon will always refer to an orthopedician who always gives steroids. Yes, we need to do an MRI. We have to establish the joint cavity is normal. We have to establish that there is an osteoporosis. Yes, a transient osteoporosis. You should not give steroids, just painkillers, calcium. It normalizes after delivery. This is a very common condition, I feel, but it is not very much described. Then you have done so many tests, backache, vital examinations, so many SLRs, Faber's test, all these things, Adams test. Now, how to proceed? Always don't jump into MRIs. Always don't jump because your CBC increased ESR more than 100 may give a clue whether it is tuberculosis or rheumatoid. You do a blood urea sugar. You do a simple urine routine because it may show simple myeloma protein or a factor, ESR, all these things. Go for USG abdomen, X-ray lumbar spines, MRI. Yes, these all the things will be actually done prior usually before we see usually. CT scan if you have bone suspicions and nerve conduction studies. Now, how will you prevent? We have covered so many things. Prevention. Strengthen your core muscles. Invest in your ergonomic office chair. Safeguard your back while lifting. I have told you how to bend and take a small cell phone from the floor. Dissipate stress stars. Rest your back for prolonged bending. Take rest after you have bent long. Protect your desk immediately after waking. Immediately after waking, don't jump and go for it. Wait. Wait for some time. Sit in your bed. Then go back. Stand for some time. Slowly walk. And then do your weightlifting and all. Stretch your hamstrings. I will always say this is the best prevention. Surya Namaskar. Don't jump after getting LBA. Coordinate with an yoga teacher or you fit to do a Surya Namaskar. After that, you do. I have already told how to go down with the knees. The knees should bend and take the pain. The other modalities of treatment is stents and acupuncture, interferential therapy, ointments and gel. I have used a lot of acupuncture in these. NSAIDs, steroids, epidural steroids. I use 40 milligram of methylprednisolone with 2 ml of local anesthetics. But it may be effective in diseases, and I feel that there is some element of systemic activity of this methylprednisolone also, other than sometimes when epidural steroids may dissipate your so-called epidural adhesions. Ultrasound guided sacroiliac joint. You just go into the back, straight put your midline, your scan, and then go back. There will be a big hump and a small hump. In between the big hump and the small hump, give the steroids a look. Think before knife. Every time you start operating for a low backache, we are going to cross problems. We are going to land up in problems because a failed back, it's a separate topic, is very refractory to any type of management. Act during subacute or acute. If you have a subacute pain, if it is going to be 3 weeks, yes, it is going to transit or it is going to transform into chronic pain. All these things are possible. Yes, a dorsal root ganglion stimulation, a TRPV1 receptors, a glial cells, CGRP, yes, target with NSAIDs here. Target with glutamate receptors with dextromethorphan and ketamine here. Magnesium, again ketamine. Sodium valproate, calcium influx. Alpha 2 agonist glial cells. Here capsaicin, opioids. As target when you have subacute pain, give these drugs and stop this chronic transition. So diagnosis, identify red flags. Diagnosis is what is 12 weeks chronic back pain from the subcostal margin to the inferior gluteal fold. Identify the red flags. I've already told you. Stop transition from acute pain. There are numerous drugs like alpha-2 agonist, sodium valproate, opioids, NSAIDs, ketamine, and dextromethorphan. Stick to basics. Don't jump into back. And which is the pain generator? Myofascial component is there. Switch on to the back of the knee on the medial side. Yes, because many times chronic backache needs rest. No. Chronic backache needs physiotherapy. An acute backache may need rest. This we need to be very clear. Yes, this needs rest or physiotherapy, we need to tell. Patient or MRI. Because if you take an MRI of a patient with some other disease, sciatica, it may show some disc. 40% have shown discs. Yes, we need to operate for the patient and not for the MRI diagnosis. Surya Namaskar, physical therapy, NSAIDs, steroids, and physiotherapy. Live with nature. Don't go against nature. No egos. Take opinions from ortho, neuro, and all, even psychiatrists. Long live the ISA. Thank you. Thank you. All my slides are available in www.painfreepartha.com for free download.